This is part 1 of our Chapter 4 content in abnormal psychology, and we'll be covering diagnostic procedures in this content. This is covered in 4 smaller slideshows, and so this is the first of those. So overall in this content, we want to identify the basic elements in assessment, describe the factors involved in assessment, and explain the interview process, clinical observation, and testing. In this content, we're not actually going to do the case study. We'll save that for a little later, but we are going to discuss how practitioners integrate assessment data and treatment planning and look at the process for classifying abnormal behavior. So this is across the 4 slides, not just in this one. So we have 2 distinct processes. The first is a psychological assessment, and that's when a clinician is trying to learn about the individual. So they're going to develop a summary of symptoms using tests, observations, and interviews. And through this process of tests, observation, and interviews, they'll be gathering information about the patient's or the client's presenting problem. And so that is the official term that's used. What is this person's presenting problem? The clinical diagnosis then is actually classifying this disorder. So first we're finding out what's going on, that's the assessment, and then we're making a diagnosis, and this involves using a clearly defined system. So the most common system in the United States is this Diagnostic and Statistical Manual, the 5th edition that we're on now, which is quite different from the 4th edition, so you can't really substitute those in anymore. And internationally, there's the International Classification of Diseases, or the ICD-10, actually ICD-11 now. And this is multiple volumes, and this actually covers not just mental health disorders, but all disorders. But of course, we're focused primarily here on the aspect of the ICD related to psychological disorders. So the sections in this DSM-5 that you have now, and you want to look it out and take a look at this. This is the week to do that. So section 1, you'll have your introduction and then some instructions on how to use a manual. So take a read through that. And then they give cautions to you about using the DSM-5 for forensic use or for courtroom use, because it's not intended for that purpose. It's intended for therapeutic purposes. So you'll want to consider that as well. And then section 2 is the primary section that we would be working with in this class when you're doing your case studies, because it includes the diagnostic criteria and the official codes that you would report if you were making a claim for insurance. And so this is a pretty big section. And so this has all been revised recently. It's eliminated it used to be an axis system that was used in the previous, and it presents the categories of diagnoses that somebody might have. Section 3 addresses things that are forthcoming that weren't resolved in this issue, like assessment measures, which are always changing, especially as we get more information about neuroscience. Cultural formulation, so understanding how culture impacts these. And then personality disorders was a major conflicting conversation at the APA as they were designing this or developing this new manual. And so this kind of looks at different ways to consider these personality disorders. And then there are some materials in the appendix that would be referenced in the body. Highlights of the changes in case you did have the DSM-4 before, technical terms, cultural concepts of distress. We mentioned a couple of those earlier, and then a little summary of these codes and diagnoses. So take a look in that document. We'll start to be using it now beginning next week. So how do we begin to assess somebody? Well, first we identify the presenting problem. And in general, we're kind of looking to see, is this problem based on a temporary situation like grief? Or is it broader than any one situation? Is it pervasive? For how long has this problem been present? Has this just emerged? Is this still acute, or has this been going on for a while? Has this happened in the past? Has this individual made prior attempts to help this problem? What was the outcome of those attempts? How is this person functioning? Is this problem impacting social roles in this person's life? And does this problem align with any DSM-5 disorder criteria? So that's what we're really trying to do as we identify the presenting problem. So how would we go about doing this? Well, we would begin with a social and behavioral history. So probably if someone was just coming in, we would start by talking about this presenting problem, find out what's going on with them, and then we would go on to find out more about them in general, to contextualize it by getting social and behavioral history. So we might take personality factors using subjective measures or projective measures, either term is accurate. Or we might use objective measures like a written test, like the MMPI, and computer analyze it. We'd understand more about their personality. Secondly, we would try to understand their social context to get a, quote, dynamic formulation of the problem. We'd want to learn, well, what's their family situation? Do they have a home? What kind of a home? What's the socioeconomic status? Is money an issue? What's employment like? How much education? Yeah. What's the friendships? These are all the kinds of things we would find out about. And we would always be aware of culture, because the way people answer these questions would really vary by culture. From an Asian culture, for example, people would be much more likely and much more comfortable identifying physical problems. And a skillful Asian practitioner might know that physical problems might represent some psychological strains. So we have to be aware of that. I think working with Navajo people, we might want to be aware that they have different interpretations of life events based in spiritual beliefs and traditions, and to avoid being offensive. There would definitely always, especially if psychiatry is involved, that there would be an assessment of general health and a neurological examination. So how would we assess the physical organism? Well, we would start with just a basic all-around physical. Medical history, pain assessment, hormonal irregularities, that sort of thing. We know that, for example, hormones can be linked to, postpartum hormones, for example, can be linked to depression. Abnormalities in non-reproductive hormones can also lead to abnormalities like thyroid. We could have a thyroid dysfunction going on, which is linked to depressive types of disorders. So we want to check out all those things and make sure we don't have simply like a nutritional deficit, or pain that the person hasn't acknowledged. So typically, if we're getting a serious good approach, we'd start there. Sometimes you can do neurological examinations. If you're like me, you might be thinking, gosh, these things are happening in the brain. Why can't we just peek in there? We have the tools, don't we? For example, excuse me, we could do an electroencephalogram, an EEG. Look at this person's brain waves. And if we can see the electrical energy from each of these electrodes on this screen, can't we see if something's wrong? And if so, don't we have a more accurate diagnosis than just asking questions? Maybe we'll see dysrhythmia, abnormal patterns, or maybe we could compare to known patterns like left frontal deactivation, maybe linked to depression. And we have little starts at that sort of thing going on. We'll talk about this more in a minute when I show you SPECT scanning, but we do have this sort of like these teasers beginning to happen, but so far we don't have good validation processes. We don't have good evidence that changes in these neurological measures are representative of pathologies. We're not there yet, but we do have some good starting points. We could have a CAT scan, which is like x-rays of the brain that can identify diseased regions in the brain. And that can be very helpful to know, because we certainly can have disease or tumors impact behaviors. Magnetic resonance imaging is more commonly used now, MRI, and it's because we can get much more precise measures of each sort of layer of the brain and the activity that's going on in there, and that level of activity is impacted. We can measure that now, and we can see exactly what's going on in the brain in different parts of the brain, where's the energy. So that fact that we can now get these really detailed images, that allows us to see the whole anatomical structure. And just like in the MMPI, we can compare it with prototypes of structures for particular disorders. So we might know what Alzheimer's looks like in the brain. And so we can compare this MRI with the MRI of someone who's suffering from Alzheimer's. So that sort of thing can happen. And we also have functional MRI or fMRI, which is the same as the MRI, except we're using really high-speed imaging, and we're gathering data while the person is engaging in a task. And so then we can see parts of the brain involved in particular processes. And your book goes over a few different interesting things that we can be observing through this. So I put this up next because I heard about this Dr. Amen and his clinic and his SPECT scans probably 15, maybe 12, 13 years ago. And what they were claiming to do was that you could go there and you could pay a certain amount of money and they would take a brain scan. And through your brain scan, they would tell you what's wrong with you. Why are you feeling so anxious and depressed? And that gives it like sort of a really, a feeling of like, well, now this feels much more scientific. It feels like something you can depend on more. And so these clinics are still existing and they're all over. Well, no, I shouldn't say they're all over, but they're used by a lot of different people. And the problem is, I looked it up to see if they had any improvement. And the problem is, no, there's still not good supportive evidence that they're getting accurate diagnoses using this process, even though they've been around 30 years. Now, they're reporting, that patients are often happy. And maybe that's just because they feel they're getting a more scientific diagnosis, but there's no evidence that it's actually any better yet. So maybe we'll get there, in your lifetime. I think we probably will, but we're not there yet. And these are complicated things and they require a bit of subjectivity. We don't have a good degree of precision yet. And then we do have neuropsychological exam tools, and you can think of how important this would be when trying to detect, say, cognitive disorders, things that are affecting thinking or one's ability to perform. And the Halsted right-hand battery is one example, and I intended to put the many things that can be assessed with this battery, but this would be to detect like neurological dysfunction. And it really looks at quite a wide range of things through a wide range of tasks. Like it would be able to detect your attentional processes, your visual scanning, your sensory. It's looking at a bunch of different things. And this is just one subtest. And I see I didn't put the larger list here, but your book does cover it. But part A is just like dot to dots you might have done as a child. So you're just given a bunch of dots and they're looking at how quickly can you scan to do this accurately. And they get more and more complicated. Part B looks at task switching because you're asked to switch from a numeric sequence to an alphabetic sequence. So you're asked to go 1 to A to 2 to B. So you're task switching. So you always have to go back and forth and remember where you were. And so here we can detect things like dementia and Alzheimer's and perhaps some cognitive malfunction. Very often what we're involved in when we're doing a psychological assessment is psychosocial assessment. And one way we do this is through interviews. And we could have a structured interview, which we have predetermined questions that are followed strictly by the clinician, even in terms of the wording. Like we might say, have you ever had periods in which you could not sleep lately? Using those exact words rather than informally saying, how has your sleep been lately? And we get more reliable data that way. We could also have unstructured interviews, which are general questions, maybe this latter question, how have you been sleeping? With individual follow-up questions. And patients appreciate this more, they feel more personalized. But the results, the diagnosis at the end is less objective and reliable than structured interviews. So we have pros and cons on both. One thing that can help with reliability is to add a rating scale to it. So at the end or over the course of the interview, the clinician might rate states or behaviors, like might rate the person's anxiety level or the person's self-esteem on a 5 or a 7-point scale. And if they're putting these ratings down, that might help make this information more objective. And this is, if you do this kind of rating in combination with a structured interview, you're going to get a stronger diagnosis, more consistent with other practitioners. But clients don't like it as much. They don't feel known and seen as much. So we have to really know the purpose of the interview. Is the purpose primarily to diagnose, or is the purpose to establish a relationship with the patient for the sake of treatment? So if it's diagnosis, then structure and rating might be important, and then perhaps just even administrative staff could do that. But if treatment is going to be happening, then it's really important to connect with that person. And then the unstructured processes might be more important. The second aspect of psychological assessment is observation. So ideally, if we're going to observe a person, we're looking for how are they behaving in a natural setting? What are they doing in their home, in their workplace, in their school? But clinicians don't generally have a chance to go into someone's home or workplace or school, so very often these are just conducted in the clinic as they arrive for their appointment. The data would be written notes about, say, hygiene. How is this person carrying themselves? What's their appearance? What are their responses like? How much time between a question and a response? Are they anxious? Can they answer questions? Are they aggressive? How do they handle the clerk? How do they handle waiting for their appointment? Do they use the bathroom? What do they do while they're waiting? By that, I don't mean to make you feel you're being spied on in the waiting room, but those are some things that might be observed. That's the idea of what might be observed if an observation is being conducted. And the purpose is just to learn about the person's psychological functioning via his or her behavior or appearance in various contexts. We have psychosocial assessment rating systems, and this is an example of the brief psychiatric rating scale, which it is a scale of, you might be rated on these different things like somatic concern. How preoccupied is this person with fear of physical illness? And the practitioner or clinician would then indicate, not present or all the way up to excessively serious. The same for anxiety or withdrawal or disorganization. So this is an example of the rating system. The Hamilton rating scale for depression is more specifically for depression. Both of these are really more used in research and to determine if the treatment is effective. So if we gave this depression rating scale and they got a score when they first came for treatment, and then 10 weeks later we got a second score and there was an improvement, then we could know that our treatment is offering the right thing.